Good evening, friends. I hope you all attended the leaderboard 2020 questions from NEET PG 2025 20 series. So I'm going to discuss 20 surgery questions. The concepts which we are going to discuss are very important topics for a NEET PG exam. 3 hours after a burn injury. So the concept is related to burn injury. That consisted of circumferential questions from NEET PG 2025 20 series. So we are going to see the questions now. 3 hours after a burn injury that consisted of circumferential third-degree burns at the wrist and elbow of the right arm. See, wrist and elbow of the right arm. A patient loses sensation to light touch in his fingers. Good evening, Ash. Good evening, Indu. Light touch in his fingers. Motor function of his digits, however, remains intact. So in this, that is only the sensation is lost. Motor function is intact. The most appropriate treatment for this plan now consists of, so elevation of the extremity and Doppler ultrasound every 4 hours, and distal pulses are absent 8 hours later, immediate escharotomy should be done. Palpation for distal pulses and immediate escharotomy if pulses are absent. Doppler ultrasound for assessment of peripheral flow and immediate escharotomy if flow is decreased. Immediate escharotomy after general anesthesia from above the elbow to below the wrist on both the medial and lateral aspects. So this question is discussing on compartment syndrome. Please understand the concept. Compartment syndrome caused by burns. Burns causing circumferential burns in the upper limb is causing a compartment syndrome. Compartment syndrome, you know, there will be loss of blood flow to the distal extremity. So most important point is last sign is loss of pulses. You should not wait until that sign. If the pulses becomes absent, means it's a last sign. So therefore, you as a surgeon should be very carefully watching these patients, and those patients who are having paresthesia and circumferential burns, immediately you should assess by Doppler ultrasound. If the flow is disturbed, then immediately what should I go for? So can you tell me the answer? What's the answer for this question? Yes, I'm watching you on the YouTube. Please tell me what is the answer for this question. Yes, what's the answer? Answer is A, B, C, D, which is correct. See, the interesting point is it's a third degree burns. Okay, it's a third degree burns. Third degree burns are painless. Please understand that basic point. So third degree burns are painless. Therefore, these burns does not need anesthesia at all. So immediate escharotomy under anesthesia not needed. No need of anesthesia itself. You can directly go for escharotomy, means opening the thickened skin so that the compartment syndrome will not happen. So do an Doppler ultrasound for assessment of peripheral flow and do immediate escharotomy if flow is decreased. That is interesting catch point here is no need of anesthesia for escharotomy. Escharotomy is painless procedure because already that scar is painless. It's a third degree burns, painless burns. So there will be no pain. You can do escharotomy without even any anesthesia. And that should be done after assessing with the Doppler ultrasound. If the flow is decreasing to the peripheral radial and ulnar artery, immediately do this procedure. See, understand the concept. This concept is related to scar causing compartment syndrome related concept. See, this already you all would have prepared. Just understand the interesting concepts I have took for this 20 questions. Maybe a little difficult, but all are important topics for NEET PG. Just understand escharotomy concept. Okay, escharotomy related concept. So in the explanation, I have provided whatever you expected. When vascular impairment is diagnosed, immediate escharotomy are indicated. Anesthesia is not required as the burn is insensate because it's a third degree burns. Don't forget that basic question. Okay, it's a third degree burns. Now, your next question, Ramavati, 40-year-old female, presented with the progressive lump in the parotid. On oral examination, the tonsil was pushed medially. Biopsy showed pleomorphic adenoma. What is the ideal treatment? Parotidectomy, superficial, total, or enucleation, or lumpectomy, which is correct answer for this. So what is the diagnosis? It's a pleomorphic adenoma arising from the deep lobe. Okay, please understand. Parotid gland is like this. This is a parotid duct called as Wharton duct. Sorry, Stenson duct. Parotid duct called as Stenson duct, which opens in the upper second molar. Don't forget, at upper second molar, it is opening. So there are two lobes. Parotid gland is divided into superficial lobe is here. Deep lobe is inside by a nerve called as facial nerve. Facial nerve with its 5 branches divides the parotid gland into superficial and deep. Yes, very good. All of you are correct. Answer is C. It's a now the tumor has been arising from the deep lobe, not from the superficial lobe. If it arises from the deep lobe, tumors will push the tonsil medially. That's the catch point here. Tonsil pushed medially. This is a catch point in this question. When the deep lobe is enlarged, it pushes the tonsil medially. Therefore, such case of deep lobe pleomorphic adenoma should do a total conservative parotidectomy. Means you should preserve facial nerve. Don't injure the facial nerve. Preserve facial nerve and do a perfect surgery of removal of superficial nerve, superficial lobe and deep lobe. Okay. Please don't forget this point. Okay. So, sir, good evening, Dr. JP sir. JP sir is our king in DocTutorials. Happy to see Dr. JP sir. Please welcome, sir. So this point you should not forget. Deep lobe is involved in parotid glands here. Hence, the ideal treatment is total conservative. So can you tell me where will you do radical parotidectomy? So radical parotidectomy is a surgery done for malignant tumors like mucoepidermoid cancer, mucoepidermoid, adenoid cystic. In all these cases, we have to do radical parotidectomy, which means superficial lobe plus facial nerve plus a deep lobe. Everything is removed in this place. And there is an interesting MCQ, very common MCQ. Good evening, sir. Radical parotidectomy. Adenoid cystic cancer can have perineural invasion. Perineural invasion, it can infiltrate into the base of skull. It can go up to the base of skull is involved in adenoid cystic cancer. So please don't forget this basic point. Adenoid cystic cancer can involve base of skull. So the answer is very simple question. Since it is pushing the tonsil, it is a deep lobe tumor, you have to go for total conservative parotidectomy. So 45 years old man presents with long history of heartburn. So heartburn is a clue. We are going to discuss a concept related to GRD, especially at the night. He uses 3 pillows to sleep and has meditated himself with a variety of antacid for the past 15 years. Recently, he has been complaining of dysphagia that he localized the precordial area. Okay. Now, a known case of GRD, now developing a dysphagia in the precordial area. So, what is a common complication? So, now reflex esophagitis going for dysphagia. What are the various causes? The question is very interesting question. Please remember, dysphagia in a GRD patient. That question is related to dysphagia in GRD patient. Dysphagia in GRD patients can be due to number 1, Skatsky ring. Skatsky ring is a thin submucosal ring. The thin submucosal ring. 2, peptic stricture. Peptic stricture is a thick stricture at the lower end of esophagus. And number 3 is adeno cancer, which is very, very rare. Adeno cancer. So these are the 3 causes of dysphagia in a GRD patient. So dysphagia can be due to any of these causes. So the most important thing I want you to tell here is from the history, the patient is having reflex esophagitis for long period. So even for a thick stricture, this is most common cause of dysphagia in a GRD case. So answer here is adenocancer of esophagus may happen, but not the correct, most likely cause. Most likely is angina pectoris, achalasia. Achalasia is not the cause because achalasia will have a different history. I know you know very well. So they have achalasia cardiac has a triad of symptoms. What are the triad of symptoms? Weight loss, regurgitation, and liquid dysphagia more than solid dysphagia. No such clue is there. Therefore, I'll go for a C. Okay, please remember the answer. Benign peptic stricture of esophagus is the best answer for this question. So this is a question related to GRD and its complications. So every year there will be a question on GRD. Please be strong in the concept of GRD. So every question when you read, you should know what concept is being asked. So second question is on pleomorphic adenoma of parotid gland. Third concept is on GRD complications. First complication we discussed, third degree burns complication. Okay, now the fourth concept is related to the benign peptic stricture of esophagus are submucosal fibrotic rings that narrow the lumen and obstruct the passage of the food. They present with the dysphagia that tend to be between 1 to 4 centimeter in length. GRD is the common cause. Other associated motility disorders often occur. Heartburn may improve because of obstruction of refluxed bile. In this is a line, very interesting line. Those who have a peptic stricture, once the stricture forms, now the acid cannot come up. The acid cannot come up beyond the stricture. So therefore, heartburn may improve. Heartburn resolves, but dysphagia happens. See how interesting concept. Dysphagia happens. It's a classical case of peptic stricture. Don't forget peptic stricture related MCQs. Okay. So there is no exam paper in any from our days of PG preparation. There will be no paper without GCS. So patient had a road traffic accident and put on mechanical ventilation. He is opening his eyes on verbal command. Moves all four limbs spontaneously. What will be his GCS score? Now tell me the GCS score. So eye opening. Easy to remember. Spontaneously opens, give 4 points. On commands, if he is opening, 3 points. When I call him, he's opening 3 points. To pain, 2 points. Not opens is 1 point. For verbal, the mnemonic is very easy. 1 confused word sounds nowhere. 1 confused word sounds nowhere is the mnemonic. Patient is oriented, give him 5 points. Confused 4 points. Inappropriate word 3 points. Bad sounds 2 points. No sound 1 point. And the same time, if he is intubated, what is the score? Yes, intubated patient will be having no score. It is called as VNT, not testable, 0 points. VNT is not testable. Finally, motor response is very easy to remember. Obey, localites with fluxion extension. Now, that's the mnemonic. Obey localites with the fluxion extension now. So obeys command 6 points. Localizes pain 5 point. Withdrawal 4 point. Fluxion deformity 3 point. Extension deformity 2 points. No response 1 point. So the patient is moving all his force spontaneously is 6 points and he is opening eyes on verbal command is 3 points. So 3 plus 6, 9 plus VNT is equal to 0. So VNT is 0. Therefore, total score is A. So the very interesting answer is A. So mechanical ventilated patients, the verbal is not testable. It is 0 points. So don't forget this score. GCS score, there will be always a question. So now a question on GCS. For a patient, GCS, motor response in right upper limb. In right upper limb, or right side of the upper limb and lower limb, there is extension rigidity. Extension rigidity. On left upper limb and left lower limb, he can localize. What is the score you give for this motor? This is a motor score. So there are 2 motor score. Right upper limb is an extension rigidity, which is having only 2 points. Left upper limb, he can localize the pain and all. So it is having 5 points. Which one will you take for calculating GCS? Take the best score. Okay, please remember, take the best score is taken. So 5 is taken in calculation. Okay, this is a very important MCQ. When there are 2 different values, take the best score. So don't forget this point. Okay, when there are 2 different values, we should take the best score among the 2. Okay, this is very important. Very good. Very good. It's 5. So now we are going to the next concept on neck dissections. Neck dissection for a oral cancer, we do neck dissection. In a supraomohyoid neck dissection, the lymph node is removed up to which level? So here I want you to understand the neck nodes. Please remember the level of Neck nodes is a common MCQ. There are how many levels of neck nodes? Can you tell me? How many levels of neck node? This is sternocleidomastoid muscle. There are 7 levels of neck node. Okay, 7 levels of neck node. Submental, submandibular is level 1. Submental, submandibular, level 1. Upper jugular is level 2. Middle jugular is level 3. Lower jugular is level 4. Upper jugular, middle jugular, lower jugular. Don't forget this. 5 is posterior group of nodes. Posterior group is 5. 6 is very important. Don't forget pre-laryngeal and pre-tracheal nodes are coming under 6. 7 is upper mediastinal nodes is 7. Upper mediastinal nodes. See, now I'm going to tell you a lot of neck node dissections. Please understand. Radical neck node dissection of Kreil's operation. We remove level of neck nodes 1 to 5. Don't forget this. For oral cancer, radical neck node dissection, we remove 1, 2, 3, 4, 5. In radical neck node dissection, we also removed spinal accessory nerve, internal jugular vein, sternocleidomastoid. All are removed in radical neck node dissection. In modified radical neck node dissection called as functional, BOCA, it is called as BOCA operation. In this, we remove 1 to 5 nodes, but preserve all these 3, spinal accessory nerve, internal jugular vein, sternocleidomastoid are preserved. Okay, don't forget this. This is for oral cancer. Radical and modified radical are done for oral cancer. Now, the most important MCQ, supraomohyoid dissection. Supraomohyoid is a dissection which is done for N0 and early N1 cases. N1 means a single node less than 3 cm or no neck node is palpable. We remove level 1, level 2, level 3 nodes. That's all. And in tongue cancer, we do extended supraomohyoid because they may have skip metastasis. Don't forget, tongue cancer can have skip metastasis. So N0 of tongue cancer alone, you will do 1, 2, 3, 4 also. So whatever I have discussed here, radical neck node dissection, modified radical neck node dissection, supraomohyoid dissection, extended supraomohyoid, all are related to oral cancer, not related to thyroid cancer. Don't get confused. In thyroid cancer, what are the level of nodes removed? In thyroid cancers, we have to remove the nodes level 2, level 3, level 4, level 5 and plus 6. 6 should be removed in thyroid cancers like papillary cancer, medullary cancer. 6 is called as central neck node dissection. So in thyroid cancer, 6 should be removed. Along with the posterolateral dissection is 2, 3, 4, 5 is called as posterolateral dissection. In all thyroid cancers, you should add up 6 also. What is the dissection done for thyroid cancer means? Posterolateral plus central neck node dissection. So which node is not needed to remove? Submental, submandibular not needed. Submental level 1 is not needed in thyroid cancer. They won't spread to level 1. So in thyroid cancers, you should remove 2, 3, 4, 5, 6 and central neck node on both sides. That is called as central neck node dissection. So I hope you are clear in this. Supraomohyoid extended dissection is done only for tongue cancer as they may have skip metastasis. So the answer is 4. Please remember, answer is C is the answer for 5th question on neck node dissection. See, all the concepts I'm explaining you because this 20 topics are not for doing 20 MCQs. I want you to learn 20 concepts at the end of this session. Okay, please remember the 20 concepts. All the questions will be looking bigger and tough. You are going to get the questions also like that in the exam due to the postponement and other issues. The question paper is going to be really tough. You should be strong enough to read and answer these type of bigger questions. Okay, so please read this question. 40-year-old man Vibhu presented with the pulmonary lesion seen on CT chest. He has history of melanoma of the skin, which was treated by wide local excision and with the negative margins and lymph node dissection. Biopsy of these pulmonary lesions turned out to be metastatic melanoma. General condition of the patient is good. There is no evidence of recurrence or any extrathoracic disease. What is the most appropriate treatment for this patient now? So now this is a malignant melanoma, already cured. Now coming to you with the solitary pulmonary mets. Can I remove it or not? That's the question. Answer is pulmonary metastectomy followed by radiotherapy, or pulmonary metastectomy, or chemotherapy, or radiation therapy, which is correct. See, one point I want you to remember for lifetime: malignant melanoma has no role of radiotherapy. Never forget this. Malignant melanoma, no use of radiotherapy. We don't use radiotherapy for melanoma. They don't respond. So melanoma has no role of radiotherapy. So strike out D and strike out DA. So chemotherapy can be given if it is having multiple mets. But the patient is having only pulmonary mets. So I'll go for a pulmonary metastectomy. So please remember, I'll only go for a pulmonary metastectomy. See, this is a metastatic tumor. I'm now making it cured. What are all tumors which are curable with a pulmonary or pulmonary isolated mets or liver isolated mets? Which all tumors you can cure it by doing surgery? The concept is very important concept, because whenever in practice what we say, see, the tumor has already spread to liver or to the lungs or to the brain, you are incurable. This is what we say in practice. But there are some tumors, even when they spread to liver or lungs, they are still going to live normally. One of the most important in this is neuroendocrine tumor. Never forget it. Neuroendocrine tumors will live normally after liver mets resection. Next, colorectal cancers. Colorectal cancers, neuroendocrine tumors, and skin cancers. Especially skin cancer, it is melanoma, is now updated, melanoma. Then soft tissue sarcoma. These are the tumors which are curable even with the mets. Please remember, neuroendocrine tumor, colorectal cancer, skin cancer with melanoma, and soft tissue sarcoma. And recently they added renal cell cancer and head and neck cancer and testicular germ cell tumors or ovarian germ cell tumors. So don't forget, pulmonary metastectomy can be performed for sarcomas, melanomas, testicular tumors, cancer of the colon, renal cell cancer, and head and neck tumors. Since the general condition of the patient is good, I can go for pulmonary metastectomy in a melanoma. So I hope you all know about melanoma. So melanoma, what is the most common type of melanoma? Yes, what is the most common type of melanoma? Most common histological type of melanoma? Yes, superficial spreading melanoma. Okay, superficial spreading melanoma. It is most common site in males is trunk. In females, it is in extremities. In females, the most common site is extremities. And which melanoma has vertical spread? Can you tell me? More of vertical spread than horizontal spread. Which melanoma? It is very bad prognosis because of that. That is nodular melanoma. Nodular melanoma goes deeper, more deeper. So it has bad prognosis. So melanoma is usually seen in white people. Which melanoma is common in black people? But even in black people, it is common in white areas, that is palm and soles. Even in black people, it is common in palms and soles. Therefore, it is acral lentiginous. There are a lot of MCQs from melanoma. Please go through melanoma MCQ points. Okay, black people, it is acral lentiginous. So a 58 years old male presented with acute onset. This is a classical MCQ. Acute onset of varicocele of the left side. You should be already able to answer this question because it's a classical clinical question for final MBBS students. What is the answer for this question? Yes, what's the answer for this question? Sudden varicocele on left side. To understand this, you should understand the anatomy of testicular vein, IVC. This is right testicular, right kidney, and this is right testicular vein. Right testicular vein. This is a right testicular vein. Now this is a left renal vein, and this is left testicular vein. Please remember, right testicular vein directly joins IVC. whereas left testicular vein joins into the renal vein. Therefore, if there is a cancer in the kidney, if it grows into the renal vein, it grows into the renal vein like this, it can obstruct this route of drainage. Therefore, suddenly they will develop acute varicocele. So, varicocele, which is irreducible, this is the only cause, because varicocele is usually reducible on lying down, but the only varicocele which is irreducible on lying down is this. Which varicocele is irreducible means left side renal cell cancer causing varicocele is irreducible. That is a very good Sharath. Absolutely correct. So that's the correct answer here. Please don't forget this. So the question answer for 7th question is cancer, renal cell cancer of kidney will have acute onset of varicocele. So irreducible varicocele is due to RCC. Can right side renal tumor cause this problem? Means yes, it can cause. When the tumor is growing like this and obstructs the IVC itself, then you can get this problem on right side also. So left side RCC, so right side RCC infiltrating IVC and causing full obstruction of IVC can cause right side varicocele occasionally. This is only hypothetical, very rare concept. Most commonly it is seen on left side because left testicular vein drains into left renal vein. Never forget this anatomy question. So secondary to varicocele. So suspicious varicocele may be secondary to RCC as a growth from renal cell cancer blocks the renal vein by a venous permeation. In RCC, varicocele does not decompose in supine position. Okay, don't forget this point. Okay, so don't worry about the other point, just leave them. 17-year boy, see the question, very big question. 17-year boy suffers an hyperextension injury of the neck when he jumps head first into a shallow pool. He does a diving. When he dives, he hits the head and get an injury in the neck. He does not lose consciousness, no loss of consciousness. He arrives at the emergency department holding his neck stiffly and complaining of severe neck pain. He says the pain is particularly severe when he tries to move his head, it is painful. He has having no neurological symptoms, no paresthesia, no neurological symptoms in the lower body. On physical examination, is found to have no areas of ecchymosis on tenderness or no deformity in the cervical spine. He has exquisite pain on deep palpation of the bony prominence. There are no neurological signs. Again and again, there is no neurological signs. No neurological signs are mainly mentioned to rule out cervical spine fracture causing spinal cord compression is not there. It is not there. Cervical spine fracture causing spinal cord injury is not there. Routine plain X-rays like anterior, posterior, lateral, open mouth view of the cervical spine showed no fracture or subluxation. So you are happy there is no fracture in the cervical vertebra. So this is an ortho-related question. No cervical spine fracture noted in. There is, however, thickening of the pretracheal space ventral to the body of C6 vertebra. So let us assume C1, 2, 3, 4, 5, 6. Near the C6 vertebra, there is a pretracheal space. There is a hematoma like this. So there is a hematoma. This is probably due to damage of the ligaments. It's due to damage of the ligaments. So ligamental injury. So what we are dealing now is a ligamental injury, cervical spine. Ligament injury is very commonly diagnosed by movement on pain. You should now immediately do what? That is the question. What should I do immediately in this case? So in the airway, breathing, circulation management of A, B, C, D, E, most of you will be remembering what is done in A. So A, B, C, D, E. In a trauma, A means it's not only airway plus cervical spine control. This is the first step. Airway plus cervical spine control, applying a Philadelphia collar. Okay. So Philadelphia collar is done. See, don't forget, this is still, I have not ruled out any fracture or spinal cord injury. So immediately, first thing, what should I do? Next step is a hard cervical collar should be done. So immediately put a hard cervical collar, he should not move anything. So according to the protocol, airway and cervical spine control comes first. And there is one small c here. Can you tell me what is this small c stands for? Before A, B, C, D, E, there is a small c added now. airway, breathing, circulation, disability, exposure. So now tell me, what does small c stands for? What is the small c stands for? Anybody? So most of the students, when this question asked, they all wrote as cervical spine control for small c. No, it is only control exsanguinating hemorrhage. It is control exsanguinating bleeding. It is not cervical spine control. Cervical spine control comes in A only. Don't forget. C stands for control exsanguinating bleeding, means a major bleeding from an IJV or a femoral artery or a femoral vein. Big bleed, not a small bleed. And there is a massive bleed, you should arrest that bleeding first. That is the meaning of control exsanguinating bleeding. Don't forget this. So very important MCQ. First thing I should do for a cervical injury is put a hard Philadelphia collar. That is explained here. Ligamentous injury should be ruled out by taking lateral radiographs in flexion and extension. The best investigation to rule out ligamentous injury is going for an MRI. So until you take an MRI and confirm there is no spinal cord or other injuries, put a hard Philadelphia collar. If there is an excessive movement, it can result in cervical spinal cord compression and serious neurological deficit. Very important. Be careful. You should immediately put a cervical spine control. Pelvic binder is for pelvic injuries. When any trauma patient comes, the 108 ambulance guys, they will put three things they should do. You know that 108 ambulance guys are trained with putting a Philadelphia collar. They will immediately put Philadelphia collar. They will put a pelvic binder until you rule out pelvic fracture and put the patient on a hard board. Hard board pelvic binder Philadelphia collar is done on shifting to hospital. Shifting time, they will do three things. Put them on a hard board, put a Philadelphia collar, put a pelvic binder, start an IV line, keep oxygen mask and shift them to hospital. And once they come to the hospital, we do airway, breathing, circulation, disability, exposure. And before ABCDE, please remember now new update is small c. So this is an ortho-related surgery question. Bony metastasis is common with all the following except, please remember, testicular tumor will not produce bony mets. Very common MCQ. The most common bony mets in females is breast. In males is prostate. Okay, so don't forget this basic question. Most common site for bony mets, overall it is breast cancer, followed by prostate cancer, renal cancer, lung cancer, follicular cancer of thyroid. Not all cancers. Usually it is by follicular cancer and finally bladder. So osteoblastic secondaries in males is due to cancer prostate. Osteoblastic secondaries in females is due to CA breast. Most common tumor to metastasize to bone in females is CA breast. And lytic expansile pulsatile lesions are seen in RCC and follicular cancer. So this is called as pulsatile secondaries. Pulsatile osteolytic secondaries are seen in follicular cancer and renal cell cancer, and most common site of METs is dorsal spine. Okay, it is in the dorsal spine. So this is a common site of bony MET. This is from ortho books, not from surgery book. Please remember the common site. Testicular tumors commonly metastasis to lungs called as cannonball METs. Cannonball METs are commonly associated with testicular tumor. So this is a repeat question. A few repeated question also added. This is a classical question on what is the stage of bed sore in this. Bed sore is stage 4 because bone is exposed here. It's a classical question. Please remember that stage 1 is only erythema is seen. 2 is partial thickness skin loss. 3 is full thickness of skin is lost. 4 is bone exposed. So partial skin, full skin, bone exposed. This is order. And now bed sore happens when the capillary occlusion pressure is more than how many millimeters? Capillary occlusion pressure more than 30 millimeters mercury. When the patient is lying continuously with a pressure of 30 millimeters mercury, this causes pressure necrosis. Indira Gandhi statue has more ornaments. That's a mnemonic for the order of bed sore. Indira Gandhi statue. Ischium, greater trochanter, sacrum, heel, malleolus, occiput is the least common site. So most common is Indira Gandhi statue has more ornaments. Least common is occiput. So most commonly it is seen in ischium, least commonly seen in occiput. Don't forget the commonest site of bed sore. And for bed sore, the latest treatment is vacuum assisted closure device of minus 125 millimeters mercury suction vacuum is used for granulation. It stimulates granulation tissue, removes the excess fluid and debris, and it forms easy healing. And later we go for delayed flap closure. Delayed flap closure is done. We don't do immediately. We wait for the area to granulate. Afterwards, we do flap closure. Okay, this is very important. Management of bed sore. So this is a classical question which will mislead you. There will be always some questions which will mislead you. This is one such question. 40 years old office executive presents with 4-hour history of left loin pain radiating to groin. Loin to groin. It's a stone in, where is the stone? Stone in ureter, which place? So loin to testicles means, please remember, this is a classical location. Loin to testicles means it is in pelvic ureteric junction, causes pain radiating to testicles. If it is in the vesico-ureteric junction, the most common site, it goes to thighs. So loin to groin is vesico-ureteric junction stone. The pain has been constant with short spells of more severe pain every 30 to 4 minutes. 40 minutes, it is a colicky pain. He informs you that his father had gout and he has similar pains in the past. A KUB and IVU confirmed the presence of a radio-opaque stone in the left ureter measuring 4 millimeter diameter. What type of stone is more likely? Yes, I'm telling you, this question will mislead you. His father only had gout. He does not have gout. So most of you will think gout history is there, so it is an uric acid stone. No, it is not uric acid stone. The clue is below. Radiopaque stone. Uric acid stone is radiolucent. Radiopaque stone, the most common, 90% of us getting a stone is calcium oxalate stone. The answer is D. This is how the questions which you know very well will mislead you. Be careful when answering the question. So the father had a gout. He is not having gout. This patient is having a typical calcium oxalate stone. The most common stone is calcium. 90% of the time, you get a stone as calcium oxalate stone, and other stones are triple phosphate stones. So most calculi less than 5 mm will pass out. So no need to worry at all. Up to 5 mm, you can wait and watch. IV fluids, hydration, antispasmodics that will make the stone pass out. Uric acid stones are different. Uric acid stones are seen in hyperuricemia patients. And it will have radiolucent nature. This is a catch point. Okay, radiolucent stones are uric acid. This question is having a radio-opaque stone. So we will go for calcium oxalate stone only. Okay. So 36-year-old man presents to emergency department after a motor vehicle crash. He is complaining of left side chest pain and abdominal pain. See the BP. BP is 130/80. Heart rate is 95. Chest X-ray shows fracture of 9, 10, 11 ribs. And CT scan shows 3 centimeter laceration in the upper pole of spleen with a small amount of blood around the spleen. No other injury is identified. Which of the following is true statement? What is the grade of this injury? Simple question. This is a splenic grading. What is the grading of splenic injury? Understand, this question is AAST, American Association Society of Trauma Grading of Spleen. I'm going to explain you now. Grade 1. Don't forget, grade 1. This is a spleen. This is a spleen. There is a hematoma like this. Less than 10% of the surface hematoma is called as grade 1. Or there is a laceration less than 1 centimeter laceration is called as grade 1. Grade 2, it is the hematoma is 10 to 50% of the surface. There is a hematoma. And the laceration is 1 to 3 centimeter laceration. Grade 3, more than 50% of the surface having hematoma, and there is more than 3 centimeter size laceration. That is a 3 centimeter size laceration. Grade 4, 25% of the spleen got devascularized. So less than 25% of the spleen got devascularized, and intracapsular bleeding. There is an intracapsular vascular bleed. There is a vascular injury with the bleeding into the capsule of the spleen. Grade 5 is extracapsular bleeding. That is a splenic injury which is bleeding into the peritoneal cavity. So into the peritoneal cavity there is bleeding, and that is more than 25% devascularized spleen or shattered spleen or splenic artery injury, main splenic artery injury. So please remember 1, 2, 3 are managed by non-operative method, 4 and 5 are done splenectomy. So in a stable patients, grade 1, 2, 3 are managed by non-operative methods. Even in splenic, in a stable patient now, stable patients, even grade 4, 5 are nowadays managed by non-operative method. This is a new line. There is no treatment based on grade. The treatment is based on the hemodynamic stability. New concept is grade 1 or it will be grade 5. If the patient is stable, manage him by non-operative method. If the patient is unstable, whatever it is, the grade 1 or grade 5, take him for surgery. In this patient, there is grade 2 injury, class 2 injury, and it may be treated non-operatively because patient is having stable hemodynamic status. That is the reason I am doing stable. So please remember the patient is hemodynamically stable. I will go for non-operative management. This is a classical question on splenic trauma. So splenic trauma related questions will be commonly asked. You should be strong in this concept. Don't forget the grading of the splenic injury, because the most common injury in the abdomen is in a blunt trauma is spleen. Definitely splenic injury will be asked in the grading of exam. So any doubts, please post in the chat box. You can ask me any doubts if you have. 70-year-old cigarette smoker presents with the right inguinal mass that has enlarged and caused discomfort in the recent months. He complains of recent difficulty with micturition and nocturia. The swelling which does not extend to scrotum and reduces when resting. The swelling which does not extend to scrotum and reduces with the swelling resting. What's the diagnosis? So this is a case of what hernia? Direct inguinal, strangulated indirect hydrocele aneurysm of femoral artery. This is a straightforward question. The answer is direct inguinal hernia. Simple question. Direct inguinal hernia. See, the hernias you should be able to answer from the anatomy. Understand the anatomy. So this question is direct hernia. Direct hernia is most common in old men who are usually it is bilateral, and it is common among people who have BPH or COPD. So this patient is a smoker, so might have that may be a clue. Indirect hernia is most common in children and young men. Children and young men commonly seen as indirect hernia, and they have most common in children and young men, and they are usually extending from deep ring to superficial ring, even they go to the scrotum. Whereas indirect hernia comes from Hasselbalch triangle to superficial ring. Usually it will not even extend to the scrotum. It will be like a spherical shape, like this, spherical shape. Whereas indirect hernia will have a pyriform shape like this. A pyriform shape like this. So it's a classical reducible hernia. That's all. It's a classical reducible hernia. Patient is having micturition difficulty, means he is having a BPH. So we go with direct inguinal hernia. The clue is very clear in the question. So hernias and all are final year clinical topics. Don't make mistakes in the questions. Okay. Straightforward, simple question. Don't make mistake. This is a Langenbach's retractor. Langenbach's is a retractor of small tissues like hernia, thyroid. When you do surgeries, we use this Langenbach retractor. I hope that you know the answer. So this is used for retraction during hernia or fibroadenoma. And these are the other retractors you should not forget. This is Langenbach retractor and this is Zerny retractor. So Zerny retractor has a split end on one side. So in between that split end, you can take sutures like this. So this is a Zerny retractor. Don't forget Zerny retractor and Langenbach retractor. So a highly expected NEET PG question, don't make mistake. There is one more retractor which looks like Langenbach, which has a wide blade like this. What is it? It looks like a Langenbach but has a wide blade. Can you tell me what is this retractor? It is used for retracting the ribs. So Langenbach, Zerny, and this is Maris retractor. Okay, don't forget the name of the retractors. Very good. So most of you are knowing the name of the retractors. Please go through all the instruments used in surgery. They will definitely ask you one instrument from surgery. Okay, this is Maris. Doyens will be like a curved one for bladder. Devers is for liver with a long like this. It will be like this. It will be like this for liver called as a dever. Doyen is used in suprapubic area like this. Doyen. So retractors are very basic question. Don't forget. Maris is the answer. Very good. Maris is correct. 45-year-old male presented to emergency with the complaints of chest pain. Interesting MCQ. Chest pain with the swallowing of a piece of meat. He reports similar episodes over the past 3 years. But today's episode was most severe. He doesn't have any history of regurgitation other than few episodes of heartburn symptoms. There is no difficulty in liquid intake or has not have any weight loss. This line is given. There is no difficulty of liquid intake and no weight loss is mainly to rule out achalasia. So this patient is having episodes of GRD is mainly meant to make you understand this is a complication of GRD. So GRD patient developed a Skatsky ring, thin ring at the squamocolumnar junction. It is also called as type B ring. They developed a complication called as, what type of dysphagia you call this as? Now tell me, what is this dysphagia called as? This is called as episodic aphasia. This is a wording for the history. So episodic aphasia means they will be normal when they eat well chewed food, solid food when they chew it well and eat. But when they eat a chicken or mutton without properly swallowing, the chicken will go and obstruct at the level of the thin ring called as Skatsky ring, which is exactly seen at squamocolumnar junction. The chicken piece goes and gets obstructed here. This is very commonly seen whenever they take some solid or thick food. This is seen in achalasia also, but achalasia have liquid dysphagia. This fellow have a intermittent episodic aphasia. And many times these patients know they have a problem and they have a bottle which is containing proteolytic enzymes. Proteolytic enzymes is used by most of these people. They will immediately think that proteolytic enzyme that will dissolve this chicken and it will go inside. This is what happens many times. But please remember, once you identify, the treatment is very easy. This is also called as type B ring. Treatment is dilatation. Simple dilatation will cause this problem. No, Skatsky ring will not present with regurgitation. Skatsky ring will not present with regurgitation because it's a very thin. The ring will allow the liquid to go in between. The contents will go inside. They may have GRD symptoms like heartburn, but it will not cause regurgitation because that is not causing obstruction of liquid food. Only this mutton piece occasionally will cause. So there is no episode of regurgitation seen. So there may be recurrent episodes of chest pain, complaints of chest pain, occurrence. He doesn't have history of regurgitation. He may have symptoms of heartburn. They want you to avoid answering achalasia. That's all. The question wants you, don't answer achalasia, go for Skatsky ring. That's the answer for this question. So there are 3 types of ring from New Bailey. Type B ring is called as Skatsky ring. It's a thin ring. It is present in 10 to 15% of normal people also, and it is usually asymptomatic. When the diameter becomes less than 13 millimeter, it causes this symptom, and the typical age is more than 40 years. And this syndrome is also called as Steakhouse syndrome. As meat is a typical initiator, this is called as Steakhouse syndrome. Treatment is dilatation. There are two more rings. A is a normally seen muscular ring. All of us will have that ring. And C is a diaphragmatic pinch. Constriction caused by diaphragm is called as C ring. So most problematic here is only B ring. A is a muscular ring. B is a Skatsky ring. C is a diaphragmatic pinching ring. Okay. 12-year boy was admitted to emergency department. This is a favorite NEET PG question. With a right testicular pain and lower abdomen pain during an athletic training. He had one episode of vomiting and constantly feels nauseous. On examination, the patient is sweating and unbearable pain. Marked tenderness and swelling in the right testicle, which is observed to be lying. Right testicle is lying horizontally like this. What is that diagnosis? It's a case of torsion testis. So torsion testis should be operated within 4 hours. If you operate within 4 hours, the testis is saved. Otherwise, the testis is gone. Don't forget this. Immediately you should operate within 4 hours. And what is the most appropriate next step is, usually if it is available, we have to go for order Doppler ultrasound of the testicular arteries. Send the patient immediately for emergency surgical exploration. Why we are sending here for emergency surgical exploration is because the time is more. The time is being, actually in this question, one point which is missing is the patient is having sweating and unbearable pain for 3 hours, like that they should have mentioned. So the time is more than 4 hours or 3 hours. It needs immediate surgery. You cannot delay. The moment you delay, the testis is going out. So please remember about testicular torsion is very common in young age. In young age, it is commonly seen. Okay. So what is the most common anomaly means? Should not forget, this is a normal lie of testis. Testis lies like this vertically in both the scrotum like this. This is a normal anatomy of testis. What happens in some of the patients? They have a congenital anomaly called as, what is this anomaly? Can you tell me? The testis is lying horizontally like this with a long mesoarchium like this. What is the name of this anomaly? This anomaly is called as Bell-Clapper anomaly, and it is bilateral always. So the patient comes to you with a torsion of testis like this. So the testis lies higher up, the testis goes up, and opposite testis lie horizontally. And when you palpate this testis, when you lift that testis, pain increases. That sign is called as Pran's sign positive. When you lift the testis, patient has pain increased. Pain increased on lifting. If it is an architis, pain decreases on lifting. Don't forget this. This is a classical torsion testis. The investigation of choice is Doppler. But if that is not available, go for treatment of choice. Exploration should be done bilaterally. Bilateral exploration by an incision called as what incision? You should put an horizontal incision like this for opening both sides scrotum. Open bilaterally by putting a horizontal incision should be done for both the testes. You should explore both the testes by a horizontal incision. So lower abdomen pain is experienced because the testis retains its embryological nerve supply, which is from T10 sympathetic pathway. That is the reason he is having a pain in the lower abdomen. You should not get confused in that. So sometimes you might be diverted to go for some other like cystitis, something like that. So don't forget, it is not related to any abdominal injury. It is only testicular pain. Because of the same nerve innervation, you can have lower abdominal pain. Okay, don't forget, don't delay the surgery due to non-availability of Doppler. 49-old man suffering from depression attempts suicide by jumping out of his window of his third-floor apartment. He requires multiple operations during a prolonged, complicated hospital stay. Endotracheal intubation is attempted in the ICU, but it is unsuccessful because of tracheal stenosis, which is attributed to the following. Okay, can you tell me what is the reason? We could not do intubation. Endotracheal intubation is attempted but unsuccessful because of tracheal stenosis. It is probably because of prolonged nasotracheal intubation. It's an ENT anesthesia surgery question. Due to long-term, patient was on ventilator due to prolonged nasotracheal intubation. The trachea went for stenosis, so we are not able to do intubation. So any object that compresses the blood supply of the tracheal mucosa or cartilage can cause stenosis. When the mean intramural pressure exceeds 30 millimeters, this problem of tracheal stenosis can happen. Don't forget this. So this tracheal stenosis is happening because of prolonged nasotracheal intubation. That is why many times the surgeons will plan for tracheostomy instead of the cuffed tube. So avoid cuffed tube for long periods. So cuffed ET tube, if you are using, you should deflate it very frequently and inflate. Deflate, inflate. That's very important. Avoid cuffed endotracheal tube for these patients. So now the 18th question, 50-year-old patient with a history of jaundice in the past has presented with the right upper quadrant abdominal pain. Please understand, interesting question from hepatobiliary. Jaundice in the past now comes to you with the right upper quadrant pain. He is having pain in this place. Examination and investigation reveals chronic cholecystitis. His LFT is now normal. No jaundice. Ultrasound shows no CBD stone. No CBD stone. Okay. Only is having stones in the gallbladder. Common bile duct is not dilated. Which is the procedure of choice now? So presently the patient is not having CBD stones. But previously he might have had CBD stones. That is why he would have had jaundice before. As of now, ultrasound normal, LFT normal, everything is normal, means patient is not having CBD stone. Take him for laparoscopic cholecystectomy. So no need to worry about CBD. Don't forget, the concept here is, if you want to rule out any presence of CBD stone or stricture, what is the investigation of choice? So investigation of choice to rule out CBD stone, or if there is any CBD stricture, what is the answer for this? Answer is MRCP. MRCP should be done. But since LFT normal here, ultrasound is normal. Ultrasound shows no intrahepatic biliary radical dilatation. No need of MRCP, not needed. See, what are the indications of MRCP means in a case of laparoscopic cholecystectomy patient? I have planned laparoscopic cholecystectomy for a patient. What are the indications of MRCP means? LFT altered. For example, alkaline phosphatase is very important indicator is increased, or ultrasound shows IHBRD means intrahepatic biliary radical dilatation, or patient has colicky pain on the day of surgery. You are planning for a surgery, suddenly the patient is having colicky pain, and that means what? Some stone has come down and may be causing obstruction in the CBD. So these are the places where we have to go for MRCP. Otherwise, I will directly go for laparoscopic cholecystectomy. Simple, straightforward question. So ERCP is done when MRCP shows stones are present. See, only when MRCP shows stones are present, then only we will go for ERCP plus sphincterotomy. ERCP is no more used for diagnostic. It is only used for therapeutic procedures when there is stones in the CBD. Otherwise, ERCP not needed at all. Only when there is a stone in the CBD, we have to go for ERCP. Otherwise, no need of ERCP. Okay, don't forget this is a simple protocol for stones in the CBD. This question is again made to misguide you to go for CBD exploration or ERCP. Nothing needed because everything else is normal. Go for laparoscopic cholecystectomy, straightforward. So 19th question, 26-year-old man Raju met with an accident and brought to emergency. The person accompanying him informed that a truck ran over the patient. Chest X-ray reveals an air fluid level in the left lung. A nasogastric tube, when it is passed, got coiled into the left chest. Can you get a clue? What case we are going to deal with? A run over accident, put a Riles tube. Riles tube goes to the chest. Which of the following is a diagnosis? Tell me what is the diagnosis. This is a case of, yes, when will you have Riles tube into the chest? It's a classical question. When there is a, this is a chest, this is abdomen. When there is a rupture of diaphragm, the contents from the abdomen, most importantly, stomach goes into the chest like this. So stomach goes inside. So therefore, when I pass the Ryle's tube goes into the stomach, which is already there in the left side of chest. So this is a case of diaphragmatic injury or a diaphragmatic rupture. This is a case of diaphragmatic rupture with having a herniation of stomach into the thoracic cavity. So what should I do for this case? I should now go for laparotomy or laparoscopic repair. Laparoscopy or laparotomy should be done. So we have to put up incision and bring back and repair it, or put a laparoscopy, bring back and repair it. So this is a case of laparotomy. The best answer here is laparotomy. So don't get confused. This is a very misguiding. Many questions I made purposefully to make you misguiding in the answer. Be careful in reading the questions. So questions will be misguiding you. I'm sure by this time all of you would have prepared very well. But the point here is avoid making silly mistakes. Understand the concept. Think multiple ways before answering the question. So there will be definitely something to make you misguide and make a question wrong. Be careful with such type of questions. And this is a case of diaphragmatic injury. Therefore, we have to go for laparotomy and repair. Okay, laparotomy or laparoscopy should be done. And repair of diaphragm. Okay, that's a 19th question. Identify the correct statement regarding skin graft and flaps. See, this is a very commonly asked MCQ. Before going to the question, plastic surgery is one of the specialty topics. Two specialty topics which will be very favorite for NEET PGs. One is plastic, another is urology. Both of the topics should be strong. Graft and flap. Please understand the basics. Graft and flap, what is the main difference? Graft is a tissue which is taken and going to be used for covering a raw area like this. And the raw area is having good vascular bed is there. This raw area is good vascular bed is there. Whereas graft has no blood flow. When you keep it over this, it will get the blood supply from the raw area. So graft has no own blood supply. It is going to cover the raw area and derive the blood supply from the raw area, and they both are going to help each other. Whereas flap is a tissue which is having its own blood vessels like this. It is having this own blood vessels like this, and this is a raw area like this. Raw area is having no vascularity, like a bone, like a tendon, like a plate, like a bony plate. So we have to bring a flap which will come and cover this raw area, which has own blood supply also. So flaps may be of many types. It can be muscular containing flaps. It can contain bone flaps. Lot of flaps are available. Flaps will be coming to cover a raw area with its own blood supply. Whereas graft is of two types. Partial graft is a thin graft called as Thiersch graft. Whereas full thickness graft is a wolf graft. There are two types of grafts. Please remember, there are two types of grafts available. Grafts and flaps. So the answer for this question is grafts are tissues that are transferred without their blood supply and they revascularize at new site. That is correct. Grafts are tissues that are transferred without their blood supply and they revascularize at new site. In pedicle flaps, various tissues often with bone and muscle are transferred. That is also correct. Full thickness grafts are useful for rebuilding nose. Only for nose skin, not for other thing. In the nose, if there is a defect in the nose skin, we can use full thickness graft. Missing elements, all the elements like cartilage and all, you cannot reconstruct. Only for the skin, you can use full thickness graft, not for all the elements. This is a little improper choice. Just remember, A and B are correct answers. Pedicle flaps contain bone, muscle, etc. Grafts are those without their blood supply and they revascularize at new site. Split thickness grafts have limited durability and are called as wolf grafts. It is wrong. It's called as Thiersch graft. This is wrong. So C and D are not correct answers. A and B are correct answers. So you can go for A plus B, whichever you have put, it is correct only. So the best single answer, if you want, if it is a single choice question, best single answer is go for A, is the single best answer. Since it's a NEET PG, you'll have a single best answer. Please remember, you should go for the best answer is A, because among the choices, which is the best should be selected for single. So sometimes the two answers may be correct. You should select which is most accurately perfect answer. You should go for that. So in such scenario, I'll go for A. But both A and B are correct only. So this is a 2020 recall from surgery, NEET PG 20 series. So please utilize the series done by DocTutorials. We are doing 20 questions recalls free session in YouTube for all of you. So please utilize this session, share with your friends, and get some extra H points from whatever source you have already read. This extra H will help you to prepare more deeper. Okay. So thank you so much. So any doubts, if you have, I'll answer, or else you can stop. So please utilize the NEET 2020 series fully. Thank you, friends.
Thank you, sir.